Okay, so a very good morning, good evening, good afternoon to all the participants and everyone who is watching. So today, welcome to Implant Expo 2021 by Dentistchannel Online. And today we have Dr.Hazem Torki from Egypt live with us, and he will be taking the webinar on peri-implant tissue and prosthetic components. So the topic itself seems pretty interesting. So a very warm welcome, Dr. Hazem Torki, for coming on board with us. And without wasting any time, I would like to start with a small introduction about Dr. Torki. He has always wanted to follow his father's footsteps in education path, believed that knowledge is gained to be given. Since 2010, Dr. Torki started to be involved in courses and surgical preventions. In 2011, he started his university teaching career at Misr International University as a clinician, where he was appointed as clinical instructor. During this time at MIU, he was one of the key staff members that helped in establishing a strong foundation for implant education. In the year 2014, Dr. Torki was appointed as the visiting lecturer for MSc and PhD students at Cairo University, where he restricted his university teaching career since 2016 at his prestigious entity. During his teaching career, he founded and designed several implant courses from short-term to one-year-long programs. He also performed several implant and periodontal workshops, gave lectures and workshops at several conferences and symposiums, addressing topics that open new insights for clinicians to apply to their daily practice. Dr. Torki is owner and founder of Torki's Dental Clinics and Academy, which is located in Cairo, Egypt. So we're very excited to start with the webinar, and to all the participants, if you have any questions in the middle of the webinar, please put those questions in Q&A box. Do not put them in chat session, and your questions will be answered by the end of the webinar. Thank you. Over to you, Doctor.
Thank you, Dr. Isha, for this beautiful introduction. And I'm happy and a pleasure for me to be here with all of you and to share all my knowledge with all of the audience. And looking forward for this interesting topic. And one of my favorite topics in implant dentistry. So I'm going to start by sharing my screen. And I hope that everything is clear now. Okay. Okay, so this topic, peri-implant tissue and prosthetic components, there's a lot of controversy and controversial theories going on in the past few years. It has gained a lot of interest in the past 2 to 3 years, and a lot of design changes has been going on in the implant design and the abutment design. And this itself affected in our daily workflow in implant dentistry. And the reason is that we weren't completely satisfied with the results that we get during the prosthetic stage. During the surgical phase, we don't see truly the results of our treatment. During the surgical phase, we only deal with one factor, which is the bone, and we don't see the aesthetic result, we don't see the functional result for the patient. And that's why it is necessary that we understand the effect of the implant and the abutment assembly together and its relation to the surrounding environment, starting from the bone during the surgical phase and connecting this to the tissue reaction and the prosthetic final outcome. And this is a factor that we need to put in our mind clearly in every single implant placement that we do. We're not only dealing with an implant or a fixture that is placed into bone, we are dealing with peri-implant tissues. And the peri-implant tissues include bone. It does not only necessarily means that we are dealing with one factor. We are dealing with bone, with tissue, we are dealing with a living organism, which is the bone itself, and we are dealing with a patient that has their own requirements and that has their own, let's say, workflow that is custom for this patient. And the key for long-term successful implant placement in the aesthetic zone is always the peri-implant tissue. It's not only about the angulation of the implant, the position of the implant. It's not about the biomaterials that we choose. It's not about the implant design or the implant manufacturer. It's about the peri-implant tissue environment. Are we providing a suitable environment for this patient? Are we providing healthy tissue conditions and healthy bone conditions for this patient? Tissue contour, bone contour, they all affect our final outcome. We will look briefly at few points that affect the peri-implant tissue environment. First of all, we will look at the emergence profile, how it affects the final aesthetic outcome and functional outcome for the patient. We're going to look at the tissue by type, how it affects the aesthetic results, and how it protects the implant abutment assembly. We're going to look at the biological width, crestal bone level, and we're going to look at about the implant abutment junction, the abutment material. What type of materials do we use today? What type of do we go for zirconia abutments, custom-made zirconia abutments? Do we go for titanium abutments? Do we go for PEEK abutments? There are a lot of choices today, and it only makes things more critical and more complicated because we have to make our decisions very carefully. We're going to also look at tissue adhesion, which is a very important topic because it relates all what we're talking about. Tissue adhesion depends on the situation of the tissue, the initial situation of the tissue, the healing protocol, and the healing sequences that we go through of socket healing and ridge healing, and the material of choice for our abutment and implant placement. And we're going to look at platform switching. We're going to also look at, I just want to move this to the other side. Okay. So we're going to also look at how can we achieve this? How can we do this day in, day out in every single implant case? How can we achieve success in our final outcome and long-term success? You can, as Michael Jordan said, you can practice shooting 8 hours a day. But if your technique is wrong, then all you become is very good at shooting the wrong way. If you used to taking impression directly on abutments, you're going to be good at taking impression directly on abutments, but definitely your final outcome will not be precise. You will not be able to take all the information, the finish line and the exact mimicking of the abutment itself. You cannot transfer that. And therefore, for you to be able to do something the right way, you have to get the fundamentals down, and the level of everything you will do will rise. So it's not about doing something frequently. It's not about doing something every day. You can place thousands of implants in the wrong way, but in the end, you're still doing it the wrong way. If you look at this case, we have an osseointegrated implant. It is surviving. The implant is surviving in the patient's mouth. But is the treatment successful? That's what we have to look in detail about that. For the patient, it was definitely not a successful treatment. The patient was not satisfied at all. The patient was in tears when she saw the results, and she could not deal with this situation. And I told her, when she arrived to me to the clinic in this situation, I told her we have a long road ahead in order for us to solve her problem. In order for us not to reach this situation, we have to look at a few factors that will help us achieve a successful, not only a surviving treatment. Primary stability, buccal plate thickness. Both these factors are really important. Even before you place your implant, you have to have expectations of how much primary stability you can achieve. The buccal plate thickness, does it make a difference whether you start with thin buccal plates or thick buccal plates? The soft tissue thickness. What do we need to do in order to treat a patient, let's say an immediate upper central, immediate implant placement that has thin tissue by type? Do we need to thicken that tissue by type, or how do we change our workflow, or how do we adapt our workflow for the patient and for this situation. The implant depth. The implant depth is of critical importance because it affects the emergence profile. It affects the shape of the final shape of the crown, and it affects the final or the amount of vertical dimension that we have for biological width and for protection of the implant abutment assembly. The temporization or the seal. Are we achieving good seal through temporization? And the buccal gap thickness. This also is an important factor because the buccal gap thickness has a very important role in deciding whether there is room for formation of the new buccal plate. If you look at this picture, the moment you extract this tooth, this buccal plate will definitely resorb. And the new buccal plate starts to form after 1 week. So do I have enough room between the implant and the buccal plate for the new buccal plate to form or not? This is also an important question. So sometimes you see disasters happening when the clinician places the implant directly contacting the buccal plate, or he might choose a wide diameter implant in an upper central or lateral, which is in close proximity to the buccal plate. And this is a disaster for the final outcome. The 1.5 to 2 millimeter rule, which is why we always need to leave space between an implant and a natural tooth. And the reason for that, we'll talk about it during the lecture, and we're going to talk in details about prosthetic components. We're going to start talking about the buccal plate thickness and immediate loading. What does the buccal plate has as an outcome or an effect to our final outcome? You can see here we have a fairly thin buccal plate, and if we can imagine that this is the case that we have in any extraction socket, this buccal plate will definitely resorb. So in our treatment plan, we have to know or adapt our treatment that we know that this buccal plate will not be there. There will be a new buccal plate. This will completely resorb, and we have to provide the environment, the perfect environment, or the optimal environment for the new buccal plate to form and form well, because this is what protects and provides contour for the ridge in the buccal region. If we look at this example, for a case, we have very thin or fairly thin buccal plate. And the moment this tooth is out of the socket, this buccal plate will definitely resorb according to the bundle bone theory, which Arujo and Lindy proposed in 2005. So now we have the bundle bone, as Arujo said, is a tooth-dependent structure. The moment you extract this tooth, the bundle bone is affected and it will vanish or resorb. And the reason for that is it's completely made of dense cortical bone, and its blood supply is dependent on the periodontal ligaments. So once you extract the tooth, the periodontal ligaments has no role at all, so it degenerates, so the blood supply to the buccal plate is gone, and therefore the bundle bone resorbs. Now, we have different scenarios and different situations in implant dentistry when we place an implant in an extraction socket. Sometimes you have thick buccal plates, sometimes we start with absence of buccal plates, and sometimes you have thin buccal plates. Each one of those sockets has to be dealt in a different way. And the way we deal with it is according to our knowledge and our scientific background and the evidence that we have that enables us to deal with each one of these sockets in a different manner. In a socket like this, we have very thick buccal plates. It's almost around a 4 millimeter thick of buccal plate, and this is going nowhere. This buccal plate will never resorb because it has good blood supply starting the day after extraction or day of extraction. But it will remodel. So instead of starting with a 4 millimeter thickness of buccal plate, it might end up in 3 or 2, but it will still preserve the required contour. So an extraction socket like this, we didn't even need to open a flap. We can just place an implant and place nothing in there. We don't need to fill the gap with anything. We don't need to try and preserve the contour until the new buccal plate is formed. We just depend on biology and the nature of healing in order for this to be processed. On the other hand, a socket like this, if dealt in the wrong way, if this is an upper central of a young female, if you deal with this extraction socket in a wrong way, you will have recession, you'll have collapse of the ridge, and you'll have an aesthetic disaster. So now we know this buccal plate will resorb. So imagine this buccal plate resorbs. Once it resorbs, is there anything that is supporting the overlying tissue? So the tissue is supported, this is the tissue and this is the buccal plate, is supported by the buccal plate. Once you remove the buccal plate, the tissue has no support. So what happens? It collapses. And actually, this is the main reason why we do immediate loading, not only for aesthetic cases. Imagine you're doing an immediate loading for a lower molar. You might say, but the patient it won't affect the patient aesthetically, but it will affect the final outcome. It will affect the aesthetic outcome. It will affect the support for the tissue because the crown that you placed is providing support for the coronal tissues. If you have no crown, if you have no buccal plate, if you have no custom healing abutment, the tissue will collapse. So the main goal of immediate loading, especially in the posterior areas and the premolar areas, is to provide support for the buccal tissue. We can go for custom healing abutment, which will give exact same results. Now, there are 4 different areas that we're going to look at, all with thin buccal plates, all with the possibility to achieve primary stability, and all 4 cases we are able to go for immediate placement and immediate loading. If we start with any of these cases, they have different scenarios and the patients are different. So they have to be done in a different manner. And always your treatment is always customized according to patient needs. We are treating a patient, we are not placing an implant or a fixture in a wall. So we are dealing with a patient that has their own demands. Put always this in your head or in your mind before you start any implant treatment or any treatment for us to say that. So we have classifications like the Kahn classification. Joseph Kahn made a great classification that made it easier for us to predict whether we can go for immediate implant placement or not, the root position or the tooth position in an alveolar ridge. And we have a class 1 sagittal position, where we have good palatal bone and good apical bone that enables us to place an implant and gain good primary stability. Alien, on the other side, he made a different classification depending on the presence or absence of the buccal plate and the buccal tissues. So these 2 classifications are very helpful in treatment planning. In this case, we have a class 1 sagittal root position and a type 2 extraction socket where we have partial loss of the buccal plate, but we have good tissue thickness. So this is the image of the cone beam X-ray after we placed the implant and we went for immediate loading. And this is the follow-up picture, our X-ray after 3 months of temporization. And you can see how thick the buccal plate became. We started with around 0.3 millimeters of buccal plate thickness, and we ended up with 3 millimeters of buccal plate thickness. This would have only happened if we were able to place the implant in a palatal position to provide enough room for the new buccal plate formation. If I had placed this implant close to the buccal plate, where will this 3 millimeters form? It wouldn't. And then disaster happens. And this is a beautiful study by Mainetti where he showed that the new buccal plate formation starts after 1 week of extraction. And the remodeling process kicks in, the old buccal plate starts to resorb, and the new buccal plate formation starts within 1 to 2 weeks after extraction. And this is the critical period where you have to provide support at a stage where you have no buccal plate. You don't have the old buccal plate or the new one. Cases like this, a lack of providing the patient with their own what they need and what the situation needs, and not respecting the peri-implant tissues, where we have recession, collapse of the ridge, and lack of treatment planning in general. We can see here it was an attempt, probably it was an attempt for a socket shield technique where it went bad. And you can see why I'm showing you this picture is you can see the buccal plate is there just because the root, even though it was mobile, but the root is still there. So the moment I extracted the roots, the buccal plate definitely will go away, to resolve. And it was a very thin buccal plate, but it was still there. And of course, the mobility of these roots caused infection, so we had to interfere. And I also informed the patient that she's going through a lot of visits in order to correct what she previously had. Now, this is actually one of my favorite cases because it went for, the treatment went for around 2 years. I didn't plan it to go for 2 years, but thankfully I did insist on completing this treatment for the patient. Now, this is the initial situation, a young male that came in with a fractured upper essential, and we decided to go for extraction of the tooth, and we can see that we have a peri-apical situation, and we had to deal with it. And today's studies, for example, WASDAR showed us that placing of implants in infected sockets and non-infected sockets, they have the same success rate. As long as we clean the infection and we debride the socket really well, and the patient is on an antibiotic regime, this is very important for the patient. Now, what we did, and as we can see from the X-ray, we have good apical bone and good palatal bone for immediate implant placement and to achieve primary stability. Now, what we did was we extracted the tooth and we filled the gap with the xenograft material. Now, you see this tissue, there are two factors that will help you support or provide support for this buccal tissue until the new buccal plate formation. The particulate bone that we placed, which is not very effective, but it helps, and the temporary crown. And in this case, we had no access for digital technology, which would have made this a lot easier. And what we did was we took a direct impression, and then we placed a healing abutment, and the patient left for around 24 hours and came back the next day to receive the temporary crown that we have fabricated. You can see how beautiful and how fast nature acts and kicks in to protect the socket. You can see the difference between this socket, which was the day of the surgery, and this healing result, where the tissue, epithelial tissue, started to creep to try to close the entry of the socket with granulation tissue and blood clots. And you can see how the particulate bone is firmly attached within the granulation tissue, so it's going nowhere. You might think, well, this bone graft will fall off, even though I have a healing abutment, but you might think it will fall off. It won't, because the blood clot forms immediately within the first 24 hours, and you can see the bone graft is incorporated within the granulation tissue, so it's going nowhere. It's providing also support. And then this is the final touches that we do on the temporary crown, and this is an X-ray where the tie base is placed and the temporary crown is in place. Now, the patient came back after 3 months, and then this is a 3-month follow-up, and this is a 4-month follow-up with the final restoration. I wasn't completely satisfied with the final restoration, but the patient was so happy with it. And what we did is that I brought back the patient in 4 months, and I realized there's something going on with the cervical tissues. And I told him, okay, I have to see you within a few weeks again in order to make sure everything is stable. And this is an image where we can see buccolingual collapse, but we have the cervical tissue level is symmetrical with the neighboring tooth. So it wasn't aesthetically affecting the patient. And I mean the word aesthetically, not functionally. Now, after 1 year, the patient disappeared and came back after 1 year. And I told him, where have you been? I needed to see you. And then I looked at the case, and now there is a problem because the tissues are inflamed. It's not normal. We need to do something about that. So I informed him that we will have to interfere and correct this situation or enhance this situation in order for him to have a restoration that will function with him through his lifetime. Now, he disappeared again and came back after 1.5 years. The situation is getting worse, and recession is just starting to act. And we need to act also in order to prevent this recession and to bring this situation back to where it started. And yet he did not take this seriously. He disappeared again, and he came back after 2 years, and recession had already proceeded, and it did happen. And this is where I told him, you're going nowhere, we're going to interfere now. And I told him we have to correct this tissue change that happened within the 2-year period. And this is very important, why we always have to follow up our patients. Things doesn't need to appear after 2 months or 1 month or a few days after replacement of the crown. You need to see your patient every 6 months. That's called maintenance therapy, and it's an important part of implant dentistry. You have to provide maintenance for your patients. You have to see them regularly to make sure everything is okay. Because in implant dentistry, things happen slowly most of the time. So we need to always make sure that everything is going well. Now, this is a summary of how we started with a temporization phase, the 4 months follow-up, the 1.5 year, and the 2 years of follow-up. And you can see how the process of recession is just starting after 1.5 years. This is the loss of the contour that we have. We have 2 problems, loss of contour and recession. We need to solve both problems. This is the way that we dealt with it. We have to provide or correct the loss of contour by going through or utilizing a subepithelial connective tissue graft in order to bring back the contour the patient had at the start. And this is the regain of contour that we achieved. And then of course, we changed the final prostration, we changed the final crown, and placed a temporary abutment where we allowed the tissue to creep in coronally. So we adjusted the temporary crown in the cervical area. And this is a situation with the old tie base. I wasn't happy at all because I needed something to prevent recession from happening in the future. I corrected the contour. Now I want to correct the problem about tissue adhesion. This will keep our tissues in a stable place. So I decided to change the material of the abutment. And this is an image where we have good contour, but we do not have optimal tissue adhesion. So we adjusted the temporary crown further, and now it's ready for going for the final impressions. And this is the initial or the situation just before us changing the abutment material. And we went for, and this is another problem that I have to also talk about. This is a crown that I just came into this and I put it into the lecture because I saw a patient that came to me with this crown. It fell off. And of course I told her I cannot cement this crown again. It had to be changed. And whoever did it to you, there was a fatal mistake. You can see how rough the cervical part of the crown is. It's totally unacceptable for tissues. Tissues, they like polished surfaces, clean and polished surfaces for adhesion to happen. Now, so Vicious, he made a beautiful study comparing the amount of surface roughness in different materials. And the best material for soft tissue and the material with least surface roughness is zirconia, polished zirconia, not glazed zirconia, not glazed Emax, not polished Emax, it's polished zirconia. Polished Emax is also close there, but ceramics when glazed, it's a terrible material for tissue adhesion. Now, this is what we changed our abutment to. We changed it into a customized zirconia abutment. After this situation, we have corrected both problems, tissue contour and tissue adhesion. And this is, you can see from this image how vertical height we have for biological width formation. We have around 3 millimeters of customized zirconia, polished zirconia, and we have around 2 millimeters or 1.5 millimeter of the tie-based titanium, polished titanium. So we have around 4.5 millimeters of tissue height for biological width to form to provide the most optimal emergence profile for this case. And this is the final aesthetic outcome after we have corrected the tissue contour and the tissue adhesion problem. And the patient was even more satisfied with that. And I was satisfied after this long journey that I had with this patient, which I'm sure I was satisfied in the end for that. And this is his final smile, and he was always smiling since then. Another example is, in a situation like this, we need to provide optimal peri-implant tissues, but sometimes we have to get the help of artificial pink tissues. So artificial porcelain, because we have started with lack of implant papilla, we had no papilla, so we had to fabricate this using pink porcelain. But we need to provide the optimal tissue health for this, not only by using pink porcelain is not a magic, it only restores areas of tissue that we can hardly restore either by intensive or extensive surgical procedures, but the base of the peri-implant tissue environment itself has to be providing the protection or protective function. Because sometimes we go for pink porcelain and we forget about the tissue health in general. Now, as I told you, we have around 4.5 millimeters of vertical height. And what we see here is the zones of attachment and zones of tissue in this assembly. We have the crown zone, which is the zone where the crown is. We have the sulcus, which has no attachment and no role in protection, so it's not part of the biological roof. And we have the epithelial or barrier zone, where we have attachment of the epithelial cells or the junction epithelium to the polished zirconia. And we have the connective tissue zone, which is attached to the titanium or polished titanium. Now, we do not want the epithelial zone and the connective tissue zone anywhere near the implant or the implant shoulder, because we see sometimes companies, they propose laser treated surfaces, polished surfaces in order for providing better tissue adhesion, but we do not want tissue on the implant. We want tissue on the abutment. We want bone on the implant and tissue on the abutment. So the role of the implant design is to be optimal for attachment or attachment to bone and also integrating to bone and not to tissue. The role of the abutment on the other side is to provide optimal attachment to soft tissue. And we can see here where we have the connective tissue attachment, and the role of the connective tissue attachment is it prevents the migration of the junction epithelium or the apical migration of the junction epithelium, which will cause recession in the future. And we can see here we have tissue in contact with bone. This is not what we want. We wanted to go for tissue in contact with the abutment. And in this study, it's a histological study of an implant, an abutment, and the crown was retrieved from the patient's mouth with the surrounding peri-implant tissue, bone and tissue. And you can see how the implant design can actually allow tissue to be in contact only with the abutment material. That's why the abutment material is of utmost importance in these days. Now, we all heard about the one-time, one abutment concept and how there's a lot of controversy about what will happen if we remove the abutment and place the healing abutment and take an impression and remove the components in and out of the implant. Some studies say it can cause recession and crestal bone loss. Some studies say it doesn't have a big effect, but logically we can think about it, and some histological studies have shown that the moment or the time we are able to place an abutment and just leave it there, not to interrupt the peri-implant environment. And it's an option that we can do, so why interrupt this attachment? Now, we also heard about the socket chamber effect. The socket chamber effect is actually based on the design of the implant abutment junction, whether it will allow for volume or space for the biological width to form, in order for tissue or the biological width or the connective tissue attachment and the epithelial attachment to form on the abutment surface and not the implant. And we can see here how narrow the abutment neck is, and we can see the mesodistal space, which is all around 360, how it provides more volume for the bone and the tissue, or the tissue attachment to form around the abutment itself. And we can see the biological width formation is in a supracrestal position and not in a subcrestal position. This is called the socket chamber effect, where we create a chamber of wound or healing where granulation tissue will form, and then tissue will mature to form a good attachment to the abutment material. And you can see here how the abutment neck is actually narrow, that allows the tissue to creep and to fill in the space and to provide a good protection for the osseointegration. Now, the portion of the implant abutment restoration complex that extends from the bone crest to the free gingival margin, this is the emergence profile. It's not about aesthetics, it's not about shape. Emergence profile is an environment, it's an assembly, it's something that a phrase that describes the bone condition, the tissue condition, the biological width, the attachment, the abutment design. All of this is called the emergence profile. It's not only about the shape of the final crown, because most of us, we used to think that emergence profile is the shape of the crown, the shape of how the crown emerges from the soft tissue. In fact, it's a portion of the implant abutment restoration complex. Now, recently there have been a big trend to change into screw retained restorations, and I believe it's safe, and it removes a big part of headache in implant dentistry, which is excess cement and peri-implantitis, which can cause to bone loss. And you can see here the excess cement has led to significant amount of bone loss. And the mechanism of how this excess cement acts is because this is according to Pauletto and Lingvicius, and they showed that the excess cement caused mechanical irritation because it's rough, caused bacterial accumulation, inflammation, and then this will lead to peri-implantitis. But studies haven't designed, or they haven't described, how abutment designs affect the excess implant on the peri-implant tissue. How can the assembly of the implant abutment junction affect the outcome of this cement on the peri-implant tissue? And why am I saying this? Is because you might have excess cement and yet have good peri-implant health. This is not according to me, I'm showing you some cases, but literature has described this well. Here we have excess cement, yet we have healthy peri-implant environment. And also here we have excess cement, and you can see the bleeding of attachment, epithelial attachment. Once we remove the temporary crown, we can see that we have healthy peri-implant attachment. And this bleeding, it doesn't mean it says inflammation. It only means that you had true attachment or adhesion. True adhesion. So once you remove the temporary crown, you will get bleeding because you cut this attachment. So I'm not advocating for being normal with excess cement or not caring about excess cement. I'm just saying that according to the abutment design or implant abutment junction, it could provide some protection from the excess cement, and you need to be careful with this. Now, and here we have excess cement, and we actually removed the excess cement, and we still had healthy peri-implant tissues. The same thing goes with ovate pontics. Ovate pontics, once you remove a bridge with an ovate pontic, you see a bleeding surface on the buccal tissues. This is because you cut the adhesion that was there. And that's why you see those bleeding points. This is after 2 years of follow-up where the bridge was in place. Now, you can see 1 year follow-up with excess cement, but the crested bone levels are completely stable. And just take note of where the excess cement position compared to the implant surface. It's at least 5 millimeters away from the implant surface. because this abutment gingival height was 5 millimeters. So we can imagine that there is 5 millimeters of tissues protecting the osseointegration or the crestal bone from this excess cement. And that's why no problem happened in this situation. Now, we need to understand that cements, they have different properties. We have different position of the excess cement, and this is the most important point. Where is your excess cement? The cement zone, I can call it, and linguistics has talked about this, like where is the position of the excess cement? Is it close to proximity to the implant shoulder? Is it 1 millimeter away, 2, 3, 4? This is important in order to prevent any complications from excess cement. And the history of periodontal condition of the patient. Of course, patients with a history of periodontitis are more susceptible to problems that can arise from excess cement. Now, the abutment selection. Implants with no platform switching, implants with minimal gingival height of abutments, like in the first image, you can see that the area where the cement could be is in close proximity to the implant shoulder. So of course, any excess cement here will cause severe bone loss and will definitely cause crestal bone loss. And who knows, it could cause or lead to implant failure. On the other side, we have a gingival height of abutment a bit higher, 1.5, and we have platform switching. So excess cement, if it was available or if it was there present, it would have a less effect on crestal bone lines. And in the third, in number C, or the third situation, you can see we have an abutment height of 3 millimeters. So if there will be excess cement, it will be at least 3 millimeters from the implant shoulder. And now we have 3 millimeters of tissue thickness or biological width for protection from any harm from the excess cement. I'm not saying that it's okay to leave it there, but I'm just saying the more protection you have, the more safe you are from excess cement. So you have to choose your cement, your abutment, and your implant depth wisely. You have to make careful decisions about all these factors before you place an implant or you place a crown over an implant. Now, and this is what we talked about, the position of the cement. And in order for us to have a clear conclusion of what we talked about today, we talked about the buccal plate and how it has a role in determining the clinical outcome of an anterior implant case, and how thin buccal plate might affect our outcome, and thick buccal plate, how do we deal with it? Do we need to go for grafts and augmentations and ridge preservation techniques when we have thick buccal plates and thick tissues in a posterior molar region? We talked about tissue and bone remodeling and how it starts after extraction immediately and immediate implant placement, which is of course affected by the materials we use and the prosthetic components together with the implant abutment design. So we have the implant abutment design, we have the prosthetic components, and we have the bone condition and tissue condition, and we have the biomaterials that we use. And we also talked about peri-implant tissue and how it protects osseointegration and its vital importance. In every single implant we place, we must make sure that we have the optimal environment for the peri-implant tissue health. And then we talked about cement retained restoration and how we can use cement retained restoration following certain protocols and guidelines in order to prevent disasters. Screw retained restorations are, of course, the most common method today, but if we have good biological understanding and choosing the correct implant abutment design, we could achieve successful cases with cement retained restorations. And that's not from myself, but research and recent studies have shown that success rates or survival rate of implants in screw retained restorations is the same as cement retained restorations. There's no difference in terms of literature and long-term successful results. Thank you for everything. I hope this lecture was beneficial for all of us. And thank you for listening, and thank you for your attendance and being here. anyone has any questions for this lecture, I will be happy to answer them all.
Thank you so much, Doctor, for the wonderful presentation. I would like to start with a small presentation before we head to the Q&A session. So Dentistchannel Online presents World Implant Expo 2021. These are the few of our keynote speakers of the expo. Now, moving on, Dentistchannel Online Pvt Ltd is a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses on different areas of dentistry, and we make sure the topics and the areas and the courses which are selected are up to the date, so that our doctors and our viewers are updated. Being a prime member of Dentistchannel Online brings you several opportunities, accredited webinars, and dental courses. Now, coming to the certificate of participation, for the people who are not a prime member with us, for the participants who are not prime member with us, they will not be awarded or given a certificate of participation. Let it be any webinar and any workshop. But even in this case, the participants are awarded with 30 CPD points. So if you are a prime member with us and you are attending the Implant Expo 2021, you will be given a certificate with 30 CPD points accredited by State Dental Association of Rhineland and Palatin, Germany. So make sure that you are a prime member with us, and the link to being prime member with us will be posted in the chat section soon. Now, the next webinars we're going to have is with Dr. Aishwarya, Dr. Himadri, Dr. Olga, and Dr. Shiva, and they are one of the most tremendous speakers we're going to have on Dentistchannel Online platform. Now, for your latest dental updates, make sure that you send your full name on this number. This is the Indian number, 973936827, so that we can keep you all updated regarding our courses, webinars, and workshops. Now, these are the list of few of our sponsors: Monoplants, Novamine, Qualia, Simple Dent, Biocon, Unicorn Denmark, JTK Bangladesh, Shastri Brothers. For recorded videos and for latest updates, make sure you follow us on Facebook, Instagram, and YouTube. Our videos are there on YouTube, and Instagram page has all the latest content. If you have any doubts, any queries, do not hesitate to DM us on Instagram, and we'll respond to you as soon as possible. All right, now we'll jump to a Q&A session. So this question is asked by Sarin, and the question is that which cement do you prefer for cement retained prosthesis?
Okay, this is a good question because there are a lot of wide variety of cements in the market today for any prosthetic restoration that we provide for our patients. But when it comes to implant dentistry, we need to choose the cement carefully because you have factors like retrievability. How easy can we retrieve the crown? If something happens, I will need to change the shade or the contour or whatever, or anything that the patient needs to be changed. So we need to keep this in mind. And whether or not it has good adhesion or good cementation properties in order for it not to frequently fall off from the patient's or from the patient's mouth, which will be really annoying for patients. So there are a few cements in the market that are specifically made for implant restorations, and they call it long-term temporary restorations, I normally, in cement retained restorations, I normally tend to go for these cements because they are designed in a way we can easily remove any excess cement, where they are in like a gel phase, where you can just like remove as much as possible of the cement as you can. And they have good adhesion, and they're good, like they have good strength in cementation, so you're sure it will not frequently fall off from the patient's mouth. And the most important thing, you can retrieve them after a few months or a few years if you need. Sometimes they stay in place for 3-4 years and even more. So I would tend to go for these situations in cement retained restorations. Again, I'm not saying cement retained restorations are better than screw retained. Sometimes it's the total opposite, or most of the time screw retained restorations are sometimes beneficial, but it's an option. It's a cheaper option, easier option, less technique sensitive option when using cement retained restoration. So we can use it sometimes in certain cases.
Okay, so that was a very yeah.
Any cement that has a long-term temporary solution would be good for an implant dentistry.
Okay, okay. So that was a very well explained answer. I think we are done with the Q&A session here. And to all the participants, the link for being a Prime member with Dentistchannel Online has been posted in the chat section. And the link to our recorded videos has been posted, and also the WhatsApp number, which you can text us to get your latest updates, has been posted. So thank you so much, participants, for being a wonderful audience. And thank you so much, Dr. Torki, for taking out time for us and for coming on Dentistchannel Online and delivering a wonderful webinar.
Thank you. Thank you for...
Thank you so much. Thank you.